Yeah, my name is Martin Blindheim. Michael asked me to speak in English because he thought that 40 minutes of Norwegian would be overdose for Danes. So I try to speak slowly and not babble too much, but if I do babble, please tell me. Where should I start? The first overdose I can remember was way back when I was a young kid in 1972. That's even before we started counting overdoses in Norway. It was not a friend of mine, an acquaintance. We'd been smoking some dope together, and he was found at home with the needle in his arm and morphine at his side. So there was no doubt why he had died. I didn't even know that he was using morphine or injecting. So this really made a great impact on me. I was very upset. So I talked to my grandmother about it. She was a wise old woman. And she looked at me and she said with her mild eyes, "Oh yes, that's exactly what happened to my best friend in 1936. And that's the way I learned that overdoses is not something new. It's something that's been happening as long as we've had opiates and injection equipment. And then since 1972, I've been working with drug use problems for, ever since. And then in 2013, when I was asked to be responsible for the national overdose strategy, I was proud to be asked, and I was glad to accept. And I worked with that until a couple of years ago when I retired. And so now I'm a private consultant. During these 40 minutes, I will tell you all about Norway, at least about the overdose strategy. And I will start with saying something about the context, and then go into the strategy, and then focus on the naloxone part of it, and then end up with some more, trying to sum up and say something about what I personally think is important for the future. See how this works? Nothing happens. How does it work? You tell me. I'm not a great technician. Then that? Not that one? That one? Yes. Well, I'll just start with a quick glance at Norway and Denmark. As you can see on the map, Norway is so much bigger than Denmark, even if we have the same population, 5.5 million, more or less. It's actually 9 times as big as Denmark. And we have 356 municipalities, whereas you have only 98. And I know that 98 is too much for Denmark, but I can tell you that 356, that's way too many in Norway, in my opinion. If you were to travel from the border with Germany and up to Skagen, Skien, it would take you 3 hours, more or less. If you started in southern Norway and went up to North Cape, you would have to go by Sweden, and you'd use at least 30 hours. And across Norway, southern Norway, would be like 8 hours, across Denmark, 3 hours as well. So the conditions it's much more difficult in one way because of geography to do anything in Norway. Because I have the feeling that if you want to go to Aarhus, for example, you just get into your car and then you drive for 2 hours and then you're there. Everything is so close here, and beside that it's so flat. You don't have fjords, you don't have mountains. But this is what it looks like. This is actually one of the first slides I made in 2014 when we started the Overdose strategy. It gives you the international context. It's around 200,000 people die from overdose or actually the technical term is drug-induced death, but I use overdose all the time because it's much more easy. Globally, every year. Little less than 6,000 in Europe, and in Norway around 270. It's increasing slightly. And what I painted in red here is the most important, that most of the overdoses globally are due to intake of opioids with injection equipment. That's so important. That's, it's like 90% of the overdoses in Norway are due to that, and 85% globally. So that's what we have to focus on. And then a glimpse on Europe. This is the EMCDDA, the European Monitoring Center for Drug and Drug Abuse in Lisbon, prints this map every year. And as you see, there is a belt of blue countries in Northern Europe. That's the injection belt. That's the overdose belt. And again, it's so much linked to injection drug use. And in Southern Europe, it was like that, like, say, 30, 40 years ago. But gradually, everything has changed in Southern Europe. People are becoming wiser, in my opinion. They snort, they inhale, they use the opioids in different ways than injection. It's not well explained by the researchers, but it's a fact. And then the death rate goes down. These are the Nordic countries, and it's not important to follow them. But you see the three. No, that's wrong. It's this one. Oh, I have to manage my. Now, what happened now? We go back. Okay. I move forward. Yeah. These are Norway, Denmark, and Sweden. More or less the same population, more or less the same rate, the same number of overdose deaths. And then Sweden, it's much higher, even if the population in Sweden is the double of the other countries. They have a higher rate and higher number of overdose deaths. This is Norway. And as you can see, we had this sharp increase in the 90s, and then the sharp decline. And then it's been more or less on the same level ever since. 270 deaths every year. It's a bit more than Denmark, a bit more than Finland as well, but it's more or less on the same level. And this is when we got the first overdose strategy, and that was hailed as a big success, or a big victory that we got it. But the really infuriating thing is that we didn't get it here. We got it like 20 years after the overdose deaths started to increase. This is the timeline of the overdose strategy in Norway. And as with almost all things in drug policies in Norway, it started with a proposal from the user organizations in 2009. They proposed an action plan. Excuse me. And then the government took up the proposition and proposed to the parliament that we should have an overdose strategy. That was claimed by the parliament, and then it was mandated to the National Directorate of Health, where I worked. And then we had the first strategy running from 2014 till 2019, and then the second strategy. And what happens now? This is what the parliament said, that the aim of both strategies should be an annual decrease in overdose mortality and a long-term zero vision for overdose death. No overdose deaths. That's a bit too ideal. I'm not so happy about that, but it's a good vision, I say. And then 10 million Norwegian kroners were allocated to the strategy every year. So that's a bit of money, not very much, but a bit of money. And we started with a motto. This is also an old photograph. This is no. This is the strategy, the paper. But the motto is, sure, you can quit drugs, but first you have to survive. Ja, visst kan du bli rusfri, men først må du overleve. That was the motto of the first overdose team in Norway in the 90s, early 90s actually, in Oslo. It was short-lived, but they coined this motto, and I think it's very good. So we decided that we would have that as the motto, and it's of course adapted from the Hippocratic Oath that in healthcare you should always start with saving lives, then give comfort and care, and if possible cure, and never harm. And drug policies all over the world has been more or less the other way around. They haven't read their Hippocrates. And we started with reading a lot of literature. The literature on overdose is vast, enormous. But this is some sort of synthesis, this and the next photograph. Perhaps the most important is that an overdose is a process, it's not an event. It takes up to, we saw this chart with the oxygen in the bloodstream earlier today, and it takes up to 10 hours to die from an overdose after the intake. And that, of course, is the window of opportunity that we use when we have naloxone. This is the period when we can give people naloxone to have them survive the overdose. We also found out that some users overdose often, others almost never, and we can't really explain that. The literature doesn't explain that, but they propose that there are genetic reasons, but also reasons that people have some inherent safety measures that they use that are unspoken. We know that most overdoses are non-fatal, 20 to 1, more or less, is what the literature says, and that overdoses are results of complex context that can be addressed. So it's linked to bad living conditions. Okay, you can do something with the living conditions. It's used to somatic diseases. Well, then you can cure the somatic diseases and do something about it. So there's a lot you can do. And we know also, it's been mentioned before today, that most overdose deaths are unintended accidents. Very few are intended. But even those who are intended are preventable. Suicides are also preventable. I won't say so much about that now. This is the other photograph that slide we made in 2014, summing up the evidence and injecting opiates, I should say, mixing opioids with alcohol and benzodiazepines after periods of abstinence, after substitution treatment, in the weeks after non-fatal overdose. That's why it's important to know that one overdose, two overdoses, that predicts a fatal overdose to a very great extent. So that's really a period you have to give people assistance. In periods of hopelessness, when you're injecting alone, of course, if you are injecting alone, no one can administer naloxone on you. And then injecting unfamiliar opioids. We all know this. And then we created the overdose card that you can find down here. It sums up the risks, sums up what you can do, and it says, like it's been mentioned also before today, that you always have to call the ambulance because people should have assistance at least 2 hours after an overdose. Then we built the strategy around 3 pillars. A long-term pillar, safer use, a short-term pillar, bystander training, and a treatment pillar. In the long run, and that is obvious, safer use is the most important we can do. We can teach people to have safety measures, never inject alone, smoke or inhale instead of injecting, snort, whatever you can do, but don't inject. And if you inject, At least we made Switch Your Habits campaign, and you can see something about that down there as well, teaching the users to inhale instead of injection. And we made smoking foil available by DNE Pharma, and we also allowed smoking training and in the user rooms. That was called injection rooms. We never said fixerum. We never said that. That would be a good term in Norway. But anyhow, this was one of the parts of the strategy. Then emergency, that's why we're here today. Administration of naloxone and performing CPR, that effectively prevents fatal outcome. So we're training users and friends in CPR. How many of you had CPR training? And how many of you have had it the last 6 months? Oh, that's good. Not very good. We should all have CPR training every 6 months. Because in an emergency, you never race to the occasion. That's bullshit. You sink to the level of your training. So if you have the training and there is an emergency, you know exactly what to do because you've been training so long. And how do you count to 30? Staying alive, staying alive, staying alive, staying alive, staying alive. Yeah. That's how we do it. And then, of course, we distribute nasal naloxone. I'll come back to the naloxone part of the strategy afterwards. And then treatment. Treatment is not a part of the strategy, actually. That's the responsibility of specialized healthcare services. But it's like we want the substitution treatment to be less strict. It's called LAR in Norway, medication-assisted rehabilitation. We want there to be less emphasis on rehabilitations and more emphasis on medication assistance, and that there shouldn't be too occupied with people using other drugs at the same time as they receive this treatment. And from January, we'll have patients in heroin-assisted treatment in Norway as well, 10 years after Denmark. So we learned from Denmark, especially from Overdose, I think. We will have a trial going in Bergen and in Oslo, 5 years trial. I said that treatment was not the focus of the strategy. So the strategy is narrow and it's very pointed on overdose prevention. But we are also supposed to influence all other strategies and action plans and measures with having an overdose focus. That's important. So that's been using quite a lot of time on that. The main method in the first strategy was to have 9 pilot municipalities spread all over Norway, and they would we paid positions in those municipalities, and they came together, I think, twice a year. Yes, it was twice a year, and developed their local overdose strategies, and then they joined together to make an overdose prevention handbook. That's published on the net. And there were also a lot of other activities, and I'd just like to mention the observation of the World Overdose Day, the 31st of August, that was mentioned here earlier. I think it's important to have that as part of a strategy because it makes it possible for the local communities to join together. And it also makes it possible to mobilize the local politicians to address a meeting or whatever it is. And this is actually from 2013, before we had developed the strategy. That's in Oslo, and that is the naloxone general, Philip Lamaya, who is addressing people, and you see, it's the same today as it was at that time. This is how we use the money. We used 45% on the network of pilot municipalities. We used 35% on the naloxone project. We used 10% on co-funding research, co-funding other initiatives, and all the rest. And that's more than 100% because we used more than 10 million every year. We used like 12 million and 13 million, and we managed to get funding from different sources. So, yeah, we used 120% every year. Now I move over to naloxone. And this is also from the EMCDDA, and this is a picture they published in 2020, and I'm not sure how accurate that is. It says that there is a national project in Sweden, which I hardly think there is. It says it's only local and regional project in Denmark. Is that right? Isn't there a national project in Denmark? Yeah, so then I think you should report to the EMCDDA differently. But anyhow, this is what the map from the EMCDDA says. These are the devices. So this is the first device, the interim device that we managed to put together. I think it's more or less like the same you used in Denmark, isn't it? That you have, well, I won't allow you to open it. But that was until 2017, and then we got Nixoid, and then afterwards we got this Ventisolve. That is my preferred one now because it's in a hard box and it's easy to carry around with you. I always have it on me when I bike around Oslo, and every now and then I come across people who overdose in the public space. Then it gives me safety to have that. So the Nixoid, I perhaps would have in my medicine cabinet at home. When I get old and have pain medication, then I think that should be in every medical cabinet. The model is that naloxone should be available for free, without prescription, in all municipalities where people who inject drugs live, in all prisons, and in all treatment facilities. It should be available for anyone interested at any time. This is the model. This is not exactly how it is. Different from Sweden, now from Denmark, it's a national project and it's a research project. It's run by the Addiction Research Center at the University in Oslo. They employ the staff. And any municipality can decide whether they want to have naloxone or not. They order it from one of the university pharmacies, and then it's refunded to the municipality by the project. So there is no cost whatever for the municipalities. There are two bottlenecks. One is, since it's a research project, users have to sign a form of consent to have their data being used in the project. There are a few users who don't want that. The majority does, but quite a few do not want that. They get the kit anyhow, but it makes the research not as valuable as it could have been. And then that it's voluntary for the municipalities to have naloxone or not. I think it should be mandatory for any municipality that have injecting drug users to have naloxone, but it's not. It's mandatory to give out sterile equipment. We can say that with the Act of Infectious Diseases, that to prevent infectious diseases, any municipality who has injecting drug users in their population have to have sterile user equipment available. We can't say that when it comes to preventing death. That's a paradox. And the model, training staff and role models to train users, that's the same as here. But the main distribution in Norway is in low threshold health facilities in the municipalities, not in the treatment, not in treatment. And the distribution is to next of kin, to friends, to police force, to security companies, to prisons, to farm treatment facilities. Well, anyone interested who might come across users who have overdosed. Kids are free, no prescription needed. Almost no prescription needed. I'll come back to that. And there are project leaders in 3 cities in Norway. There is a web page that you can look at later. I don't think we have the time to do it now. And this is the logo. It's on my, well, we don't see it so well. But can you see what it is? This is the naloxone coming into the nose, going into the brain. I think it's neat. I like that. On the web page, there is an interactive map of all the places in Norway where you can get naloxone. So you click on one of the buttons and you get the address and the telephone number. That's valuable because the web pages of the municipalities are just nil, at least for drug users. This is the state. No. How do I get back? No. Tell me how I get back. Because I was going to point that. There are 40 plus municipalities that have naloxone now. And that's municipalities with 75% of the overdose deaths in 2018 occurred. Is that good? No. It's not good enough, because there are almost 200 municipalities where people have died from overdose the last 4 years. So they say there is 160 municipalities where we should have had naloxone. There are several hundred treatment centers in Norway. If you combine the drug-free treatment centers and the opioid substitution treatment, only 39 give out naloxone to excuse me, to their patients when they leave the treatment. There are 49 prisons in Norway, only 16 have naloxone so far. So, okay, we're on our way, but there is a long way to go still. Things take time, even in Norway. Pharmacies, that's a special case. To get a naloxone kit in the pharmacy, you have to have a prescription. And not only do you have to have a prescription, you have to have a prescription because you are prone to have an overdose. So I was told this yesterday. I can't go into a pharmacy and say, not to go to my doctor and say, can you give me a prescription for naloxone? Oh, do you think you will overdose? He will have to ask me. And then I say, no, it's just in case. Then he'll say that, oh, no, then I can't give you a prescription. I'm not allowed to do that. That's just plain stupid, in my opinion. But anyhow, this is also refunded from the project. So I say that with the aim of making naloxone freely available to anybody who's interested, we are on a good path. And these are the numbers of the distribution in Norway by October. We have almost 15,000 naloxone kits have been distributed since we started in 2014. And also in the year of the pandemic, we managed to distribute 4,000 kits. I think that's pretty good. And a bit more than 10,000 persons receiving kits have consented to have their data included in the research project. I'm not sure if these are unique persons, or if it's if you come back, are you then counted into that number? So I have to find out that. Half of the kits have that are distributed have reportedly been used in overdose. I think that's pretty good. And 90% of those administered on people who had overdosed have been successful. That is very good. So at least it gives you a picture of where we are in Norway now. And the annual budget for the project is 5 million Norwegian kroner. And just now, a week before I went down here to Copenhagen, the former government, before it was changed into new government, they gave the naloxone project 2 million kroner extra to spend this year to speed up distribution. So I guess this implies that the former government are not totally satisfied with the pace of the distribution in Norway. Yeah. So back to the strategy. What has been achieved? Okay. The aim from the Parliament was that an annual decrease in overdose mortality, long-term zero vision. And after 7-8 years of strategy, we're not even getting closer. So if we compare the results with the aims of the Parliament, it's been a failure. Or has it? If we look into the numbers, we can see that the heroin overdose deaths have gone steeply down during these years. So we've been successful there, whereas the other opiates have been increasing. But anyhow, I think you can say it's failed, you can say it's success, but you can say that the strategy has not yet arrived where it should be, so we do not know if the strategy is a success or not. That's what I would say. We need more time. Because I think the aim is achievable. It will take time, it will cost money, and it will take a concerted effort to get there. And we're not even close to have a concerted effort either, I don't think, as I've shown. And since day one, we said that we have to look at the traffic safety strategies that have been running for 50 years in Norway. And the traffic mortality is at the moment at an all-time low. It was at an all-time high in the 1970s. Now it's an all-time low, much lower than the overdose fatalities number. So I think it's been using hundreds and hundreds and hundreds of millions of kroners to get there. So with the 60-70 million kroners we've used for 7-8 years, I don't think we should be expected to be at the goal right now. Yet. This is the logo of the traffic safety campaign in Norway. We have a vision: 0 killed, 0 seriously wounded. And one of the reasons that we're not getting there is that there are so many factors influencing drug use mortality. For example, the availability of opioids. The national overdose strategy in Norway has none influence whatsoever in what's going on in Afghanistan. Still, what's going on in Afghanistan and the politics of the Taliban will have a great influence on the availability of opioids in Europe and Norway. We don't know what kind of efficient treatments we might get. The change in opiate substitution treatment in Norway. And especially I'm concerned about the increased user involvement. I think that's vital to having a successful strategy. And perhaps can we achieve a more responsible user culture? That's the safer use in the long term that I think is the most important we can work with. So John Strang has been mentioned several times before today. This is a quote from his. Basically, we need to educate users and their kin. We need to turn persons who inject drugs into part-time paramedics. We need to make harm reduction agencies and users collaborate in educating the user community in safer drug use. There is a danger that we get too preoccupied with medication and naloxone. And I think that he's totally right. Because we put all our hopes on treatment, or all our hopes on naloxone, or whatever chemical substance we put our hopes on. But we have to put our hopes on the user culture and making that a more responsible culture. And I think we have to learn from the high-risk activities. In skydiving, in parachuting, in diving, there is a huge emphasis on a safety culture. And it's been very successful. There are actually quite few diving accidents and fatal diving accidents and fatal parachuting accidents around, compared to how many participate in this or in mountain climbing. So we have to look into the safety campaigns that have been run in these activities. We have to look into the safety campaigns in the industries, in the high-risk industries, and learn from them and see how their experiences can be translated into the user culture field. And we have to learn from the survivors, those who didn't die from overdose, those who have been drug users for many years, but who never died. What made them survive? What kind of safety knowledge do they have that is unspoken? We have to have anthropologists interview these people in depth with user participation and find out what's going on in their heads. How do they prevent their overdose? I think that's vital, and there is very, very little research in these fields that I come across. So we adapted that. We have to learn from the other strategies I said, and we adapted that zero vision from the traffic safety. So the official Norwegian vision is that we have a vision of Norway assisting drug users in such a way that no one will die from their habit. That is the official zero vision in Norway, endorsed by the government and the parliament. And I think that's pretty radical. I think it's good. And we have to use that much more than we do. So, thank you.
So, just to be very clear about this, half of the antidotes giving out is used
in an actual overdose.
I never heard that high number.
90% have been successful.
Okay.
We don't know that all these people would have died if they had not been giving antidote.
No.
But we know that antidote was used when they had an overdose.
Yeah. In the US, 5 antidotes out and 1 is used. In the EU, 9 antidotes out and 1 is used. But in Norway, it's half. You're good. How do you do that?
I think the thing is that we mainly distribute through the low threshold health facilities in the municipalities that work so closely with the users. They are seeing many of them every day, so they can do the training again and again. They can talk about it again and again. It's not just that you meet someone in the street and you give them a kit or naloxone and then you never see them again. That's also good. But I think this person-to-person contact is perhaps the most important factor.
Okay.
But we have police who have naloxone in their cars. We have security personnel who have naloxone in their cars. We have a lot of people who have naloxone in their cars in the big city centers. And I haven't seen the figures broken down. How many times did the police force use naloxone? How many times did the security forces use naloxone? But I like to see that. And since we now have all the data, I'm sure that Desiree Ada, who is the researcher at Seraph doing this, will come up with those numbers.
Christians?
Christians? Yes, we give it to the Christians as well. And the Muslims. No discrimination.
All right. Well, thank you so much. Interesting presentation, but I was puzzled by the fact that you have this switch your habit program in your national strategy. Is this something that has any measurable effects, or is it something that you have had any kind of experience in as far as results come?
There's no research on that, and what we say is that one dose of heroin not injected is a possible overdose prevented. So this far we say that we don't think that many people will switch totally. We think that a few people would look into it, get the training, and then maybe do it once or twice if they have a lot of money, because they conceive that this is more expensive than injecting. We saw that during the pandemic, the number of overdose deaths went up in Norway, and we think that is due to it was hard to get a hold of heroin, and people were sitting in their flats injecting alone. Very few were smoking, because smoking heroin is a social habit. You sit in a group, and you're not with your head on your knees. You're much more alert. You can talk to people. Maybe people will say, "Oh well, this Saturday night we will have some people over, and then we smoke instead of injecting." We have to have people investigating this. And I would love to know more about how this happened in Southern Europe. I know that in the Netherlands, the dominant user group were the people from Suriname coming to the Netherlands, and they never injected because they had this cultural taboo about putting a needle in their arm. So and they dominated the trade in the Netherlands. So they had the availability of smokable heroin, and then it gradually changed actually in the course of 10 years. So from 95% injecting, then it's 5% injecting. I love to see that in Norway. I don't think we can influence users so much, but I think we have to teach them that there are safer ways of doing things, and that they can investigate that. And not only opioids, but all drugs can be used in more harmful or safer ways. So this is also a long-term strategy, I think. Did that answer your question? Yeah. But it's not that I think that, oh, well, I think you should, do you think I should inhale? Oh, yes, I'll do that from now on. We don't think people change that way. We think that people investigate things and then find out on their own, and maybe they do it more often than before.
With some things is working well, something is not with the national strategy. Now you're here. If you should stay here, what should we do?
You should come to Norway with your activism.
Yeah. Okay.
There's too little activism in this field now.
Okay.
Yeah.
Yeah. But see you there then.
Yeah.
But,
Well, maybe we should change countries every now.
Yeah.
and
Yeah.
then. But at least I think we should have much more inter-Nordic cooperation.
Yeah.
We should have Nordic conferences.
But I don't know if you like it here. But now you're going to stay here and you're going to implement a plan to cut down overdose death in Denmark. How will you do it?
Start talking to the user organizations, have them make a concerted campaign, because without the user organizations, none of this would have happened. Almost no change would have happened in Norway. So it's user organizations working with influential people and with politicians. That has changed. Most of the measures in the Overdose strategy were first proposed by the user organizations. We just picked them up. So, yeah, that is changing the whole ball. Nothing about us without us.
No.
So, but you have good politicians in. Perhaps we have stronger user organizations in Norway now with more political influence, especially with the last government that, strangely enough, was the Conservative government. We had a Minister of Health that was excellent. And, for example, my friend Arild Knudsen, who's the leader of one of the user organizations, he could call the minister and say, could we meet next week? And then the minister would set up a meeting. I couldn't do that.
No. Any more questions? Thank you very much for taking your time, traveling to Denmark, inspiring us. Thank you very much.
Thanks for inviting me.